Again, thank you for joining us. I'm so glad that the last session sparked some good conversation in the room, so thank you again. For those in the back, please grab your coffee and head back to your seats. So why don't we go ahead and then get started with our next panel. Our moderator for the next panel is Dr. Sneha Jain. Dr. Jain is a clinical assistant professor of medicine in the Division of Cardiovascular Medicine at Stanford University. And she also is the director of the Guide AI Lab at Stanford. Her research focuses on the development and responsible evaluation of AI tools to augment healthcare delivery and improve patient outcomes. And she works with the data science team at Stanford Healthcare to deploy and prospectively evaluate AI solutions across the healthcare enterprise. So Dr. Jain, thank you for joining us, and I'll hand it over to you to introduce our panelists. Thank you.
Wonderful. Thank you everyone for being here, and what a fantastic conversation already that we've had this morning. This next session is really going to focus on what does trust mean across different stakeholders within the healthcare system, and what's the balance between trust and speed of innovation? Do they work together? Are they sometimes slowing each other down? What do we think about that? And so to start off, and we'll probably do about 40 minutes of conversation here, 40 to 45 minutes, and then go to 20 minutes of Q&A, because I want to make sure that this is a dialogue and a discussion with the audience. You already have had such great questions, and I want to make sure that those are highlighted. So to kick us off, I'm actually going to ask each of you to introduce yourself and share what is most top of mind to you now. And if you could ground it in your perspectives, as well as your experiences with your organizations, that would be fantastic. So Grace, let's start with you.
Hi, good morning, everyone. I'm Grace Cordovano. I'm a board-certified patient advocate specializing in the oncology space. My day-to-day is working with patients and their loved ones from point of diagnosis through survivorship or end-of-life care planning. I've had the privilege of working with a few people here in the audience on the National Academy of Medicine's AI Code of Conduct project, as well as I'm a co-author on the Light Collective's AI Right for Patients, and most recently partnered with Google and the Digital Medicine Society on the launch of the AI Implementation Playbook. What's top of mind for me? When I think about this, it's recognizing that patients and their families are end users of AI. And what do we do and how do we help patients and families and communities when there isn't a doctor or a nurse in sight, when their phone calls and messages are not returned, when they're sent home to die, when they don't have a diagnosis, and when they're suffering and they want to be engaged in their care but can't get there. The last 3 years using AI tools that are openly available have been transformational in my patient advocacy work as the primary care partner to 2 disabled adults, and as I navigate my own journey as a patient. Looking forward to this conversation.
Thank you, Grace. John.
Sure. Well, good morning. I'm John Whyte. I am the CEO of the American Medical Association for about the past 4 months. Prior to that, where I've met many of you over the years, I was the chief medical officer at WebMD. I'm an internal medicine physician, and up until a few months ago, I actually worked at Kaiser Permanente. So it's great to see a bunch of the folks from Kaiser. You know, what I'm particularly interested in the conversations is how do we address clinical workflow? There's a lot of tools and ideas out there that don't work because they don't recognize how the workforce actually solves problems. And sometimes I think we're not starting with the problem and we're starting with a solution, and then we're surprised why they don't work. And I think an example of that is the issue of wearables, where there's continuous data over time, collecting in the home and elsewhere, which is really the future of healthcare. And we can argue that, oh, they're not medically grade, but this is iterative. They're going to get better. But if we don't have a way to get that data in terms of the workflow of clinicians, which is what we're seeing here, it's not going to gain the value of the technology. So that's what's top of mind to me.
Wonderful, thank you. Micky.
Great, hi, I'm Micky Tripathi. I'm the Chief AI Implementation Officer at Mayo Clinic. Really delighted to be here. Thanks for the opportunity to be here. Just prior to taking my role at Mayo, which I took in May of this year, I was the Assistant Secretary for Technology Policy, National Coordinator for Health IT, and Chief Health AI Officer at the the U.S. Department of Health and Human Services. So top of mind for me is, and particularly in my role, is how do we strike the right balance between misuse, concerns about misuse of AI, and misuse and the opportunities that come from that. So we have a lot of focus on misuse, and certainly within Mayo and at the federal government level, we've had a lot of focus on what are the potentials for misuse, and it doesn't take much to sort of go down the possible parade of horribles, and many of them real. I don't want to dismiss that, but I think that we need to pay at least equal, if not more, attention to the misuse opportunities. Our healthcare system is not perfect by any stretch, and the opportunities for us to be able to use these technologies to rectify and indeed transform our healthcare system in ways that would be incredibly valuable for patients, I think is something that we really need to be paying a lot of attention to as we think about the enablement of these technologies. I think another concern related to that is, how do we make sure that these AI technologies aren't just paving over the cow paths, which I think Bakul was getting a little bit on part of the previous session that I heard. These kinds of technologies have the real potential to be transformative in many, many ways. And so we want to be able to say, how do we, not have those blinders on to the ways that we think about the existing healthcare system and really think about, the transformative potential of these technologies.
So there are two pieces that I think are really interesting here that I want to hear people's thoughts on. One that we'll come back to later is this idea of innovating within existing workflows versus creating new pathways for care delivery and what that looks like. That's hard, but how do we do that? But the first thing I want to talk about is this concept you were talking about misused versus misuse. And I think it gets to this idea of innovation versus trust as well. How do we think through innovating quickly versus doing what we need to do to build trust so that AI tools can have as high impact as possible? So we'll go in reverse order now. If you could talk about what you think trust means from the different stakeholder perspectives that each of you carry, health system, and maybe, Micky, if you could put on your old FDA hat if you want to, a little bit of that from the regulatory perspective. From a physician perspective, from a patient perspective, what does trust mean, and what are examples of when trust and innovation can accelerate each other, or are they in conflict?
Sure. So, I think maybe starting with the most important first is that we absolutely have to have the trust of patients, and Grace will be able to speak much more eloquently than me on that. But that's the bedrock, right? If we don't have the trust of patients at the end of the day, then none of this makes sense, and none of this arguably is ethical, right? If patients don't trust what their providers are doing, that is highly unethical and not the way our medical system works. But from our perspective, then, that is, as it translates into a healthcare system, we work very, very hard to make sure that that trust that patients have in the Mayo Clinic, in our case, in everything that we do, in our processes, in our procedures, in our providers, in the entire healthcare system, that as we think about AI and the uses of AI, that builds on the trust that they already have placed in us. And we want to be able to have that kind of relationship with our patients, that the uses of technology that we believe are in their best interest and will allow us to provide higher quality, more valuable, more cost-effective care for them are something that they place their trust in our ability to be able to do that, as well as be able to share with them the benefits of that and the opportunities that are there for them. So, I think that there's a couple of dimensions to that. One is we want to be able to have more patient-facing technologies to allow them to be more directly involved in their care and have more agency, both themselves, to be able to say, from what we think of as pre-visit now to post-visit, which itself, I would argue, is kind of an archaic notion, right? I mean, if we start to think about this as more continuous sort of spectrum of people drop in and out of the sick care system, but they actually have a whole set of technologies now that allow them to really be doing much more on their own to the extent that they want to. We're working on the abilities to have more technologies that will be available to patients, working in concert with the providers at Mayo Clinic to give them greater agency, to give them better abilities to do things that they might want to be able to do on their own. And then being able to have those technologies that are incorporated in the patient journey that they have once they hit either the physical or the virtual door of Mayo Clinic to be able to say, and there's a whole bunch of technologies that we're able to make available there that we want to make sure that that they understand, that they have trust in, and that are delivering valuable care to them. I think it's an interesting question of how much do you tell patients about AI technologies? Not because we don't want them, we don't want transparency, but I think we're going to come to a point where these technologies are so embedded in almost everything we do that you get to a challenge of, well, how much can I say? How much can we say? Oh, that AI's in this, and it's in this, and it's in scheduling system, and it's in this, and it's in this. And so I think that that's something that we need to figure out. Obviously working on the basis of what are the kinds of things that we want to make sure that patients want to know, and then we're able to make that available to them. But also, how are we not overburdening them and hammering them with information that just may not be of interest to them, or may carry a whole other set of issues just related with they're already burdened with too many clipboards, right? The clipboard phenomenon. How do you not overburden them yet with another whole set of things that that may not be kind of relevant to their consideration. So those are all things that we have to work very hard with the patient community to better understand as we think about these technologies.
That's wonderful. Thank you. John,
Sure.
go ahead.
And maybe just to spruce it up a bit,
Yeah.
I'd say, in listening to that, it almost sounds a very paternalistic approach. How much should we tell patients? I don't know how much they need to know. We should be very transparent with patients and give them all the information that they need, not what we feel they need to know. I think part of the challenge is we ourselves may not be able to adequately explain how these technologies work. I mean, if you asked me a year ago, how do physicians perceive AI, it'd be very different than it is today. And in our own surveys, we know that roughly 2/3 of physicians are encouraged by the use of AI. And that's significantly more than the previous year. Before it was really 50-50. It's concerned as encouraged. Roughly 2/3 of physicians say they use AI. The reality is they're probably talking about things like AI scribe and some, back office expertise. That's not where we're going in an AI. But when you talk to physicians about what's going to get them to trust AI, part of it is the regulatory role. Many of them have talked about the role of the FDA approving a tool or clearing a tool. And then what I think has been very interesting that we don't always see, clinicians want to see that feedback loop. So if there's an error in these tools, how does that information get addressed? And how does that improve the process? I think as it comes to trust, a great example could be chatbots, right? In terms of how do patients know, first of all, it's kind of obvious sometimes we get confused whether it is a human or not.
Yeah.
That's the first thing, which would be kind of obvious, you'd think, but people do get confused by that. But how do they know that the information that they're being given, that they can trust? And that's where I think we're going to have a lot of discussion as these tools become more sophisticated.
I love this. Yes. And we'll go back to the patient perspective a little bit because, I want to understand what trust means for patients and also how we embed patients in the decision-making process of what AI tools we are using, how to use them. And this reminds me of a conversation, Grace, you and I have had where it's kind of incredible what patients are doing with their data right now. There are a number of folks. I have a colleague whose mom had a recent cancer diagnosis, and she is feeding her, her notes, her medical notes, and then she got up-to-date, information or guideline information into Notebook LM, and she's listening to a podcast about what's going on with her care, pausing it to ask questions, which she can do with this podcast, to get a better understanding of her health. And we know that that's so important because so many patients they leave doctor's appointments not really understanding what just happened. And how do we enable safe use like this and encourage our patients to use things that make sense while also supporting them in whatever their priorities are?
Oh, so many things to touch on here. I just wanted to recognize that Bakul did such an amazing job by sharing those two videos. And I really want the link to those because what it shows you is when we're all sitting here very casually, we're not in the emergency room, we don't have 60 seconds to make a decision. We didn't just learn that either ourselves or a loved one has a cancer diagnosis that's no longer responding to treatment or something life-altering, life-limiting. The world that I live in that's the world that I live in. The patients that I serve, that I have the privilege of serving, need access to not just information, tools, and technology, they need personalized intelligence so that they can make an actionable decision to operationalize. I want to give my patients a competitive opportunity and a competitive advantage against their diagnosis and against the friction and the fragmentation in our healthcare system. So when we think about trust, I look at just the examples this morning, the Bakul, that you shared in your video. A parent gets a earth-shattering diagnosis on their 7-month-old child. Would I love to spend the next 7 months with my doctor, one-on-one, partnering and working? Absolutely, but I don't have that. And many people don't have access to care. They may not have a trusted relationship with a physician. So now we can upskill and start working somewhere. Can we do a better job? Absolutely. With the diagnosis should come maybe a simple sheet of responsible prompts, and here's some peer health support, and here's a community health worker that can help support you. We need a point person inside our healthcare system where a patient and a family can go to learn and explore with curiosity about AI. And Micky, going back to some of your comments on what patients need to know, here's where we completely dropped the ball. We've been using AI successfully in our infrastructure and workflows for well over a decade. We don't talk about it at all. That this has transformed scheduling, that this transforms how we route patients from the emergency room to make sure that there's a bed, how we triage and make sure that this radiology is exactly this diagnosis. We don't celebrate the good that's already been happening. So what's happened is journalists have gotten hold of all these things, and now there's fear-mongering. And now, when a patient comes into the exam room, we have so many successes. Daniel and I recently were on a panel, and he shared his 6-month success with what's been happening with ambient listening technology. And when I go into an exam room with patients, I'm seeing consent being asked for, the technology being explained. And before we hit record, my patient and my family say, oh, but I want to use my tool and technology to record too. And it's an immediate friction point. We don't do it that way. You can't use that. That's not HIPAA compliant, and an immediate friction point. So I'm seeing this break off in trust as I'm talking about trust. There's this expectation that patients need to trust their doctor, their healthcare system, their providers, their payers, their community health system. But we don't get that trust to use the tools ourselves, and the majority of the care is happening in our home. And when I think about how responsible adoption, implementation, deployment, we need to bring community voices. We need to bring diverse perspectives, because I can assure you, like any bell curve, there are advanced users. There are people that are teaching and coaching their communities, their families, their patients, who we could all learn from. So please, let's include the patient and care partner perspective in all of this and co-create and solve this, because no one knows it all.
So fantastic. Let's stick on this point for a little bit, on having patients at the center of the development, the use, the design process. And I'm curious to, maybe we can share kind of in our own institutions how we've tried to do this, and we can kind of work together to figure out how we can do this better. I know at least at Stanford, part of what we do for AI tools that we deploy in the healthcare system is every single one of those tools, we have a discussion during our ethics evaluation with patients and with families. And there is a patient and family group that we bring their perspective into how things should be deployed. And one thing that's fascinating is you see that there are so many different priorities. Let's take a very simple AI algorithm, maybe some sort of deep learning model that identifies patients at high risk for a certain disease. I'm a cardiologist, so we'll say structural heart disease. The physicians are thinking about capacity concerns, making sure that they get the people who they can do the most medically. But patients often are saying, hey, if I have any kind of problem, I want to know about it so that I can take preventive steps. I can see if there's prevention out there. And so the threshold in which notification based on an AI tool should happen is even different between patients and providers. So I'm curious, that's just one example, but let's maybe go through and talk about how we've incorporated patients and how we can do a better job incorporating patients in decision-making around AI.
Ooh, I think we have a lot of work to do in how we incorporate. And I actually love the example that you shared, how Stanford is engaging through patient-family advisory councils. That's a starting point, but that's not the solution. We need a budget line item here to support and compensate the leadership and expertise, the time. If we don't do that, then only those that can show up to a patient family advisory council, those that have transportation, those that have paid time off, will dedicate the time.
Yes.
And these are longitudinal efforts. This is not, okay, let's meet for a focus group. Here's a bagel and a coffee. Thank you so much. I love the feedback of providing value in the last conversation. So we're inviting, in some cases, patients and communities to share their thoughts, but we're not saying what difference it made. That's not engagement, that's extraction. There's a difference. Sharing that feedback loop is incredibly important for building trust, and then having that open dialogue of constantly having this flow of knowledge exchange. A lot of work left to do, but I do feel, I'm going to encourage everyone, if you haven't already, follow the Light Collective. Take a look at the AI Rights for Patients, because that was done in partnership with diverse representation of patient voices. And there's 7 pillars there that really outline what patients want and need with respect to AI in healthcare. There's a survey there that was done by the Light Collective that said the majority of patients do want to know, over 90% want to know where AI is used in their healthcare. And I know, Micky, you and I have had this conversation about, well, now if an output is generated from an AI-powered tool or technology, and if that output is used to make an informed decision about an individual's care or coordination of care, doesn't that fall under the designated record set? And shouldn't a patient have access to that output? And where it matters, so use cases are great for healthcare. We always talk about use cases. My patients that need to go to tumor board, my patients who no longer who have exhausted all standard of care, that output could help maybe get them into a clinical trial. Having all of that information could help power research for rare disease. We just don't have access to those outputs, and I understand that there's no standards or structured format really for the exchange and flow of that information yet. So I think as we're going to build trust, the more these tools are deployed, yes, I as a patient would love to have that information in my medical record so that I can take it and use it as I wish, and also share it with my care team in confidence.
Amazing. Micky?
I'm just going back, I was thinking about John's comment and Grace's following comments. And, I wasn't suggesting that we deny information to patients. Mayo Clinic's motto and vision and core mission statement is the patient always comes first. I was talking more about the practical reality of, as these solutions start to become more and more prevalent, it start to face just the practical reality of what is it. So, we use a bridge, and we use ambience, and we use a couple of other solutions across the practice. Every single time the patient is asked for consent to use those tools, right? So anything like that, absolutely, you're getting consent. But let me give you a couple of other examples. We use open evidence, as many provider organizations do. We've used UpToDate for years. We never asked a patient's permission to use UpToDate. Now we're using open evidence. I will almost guarantee you that provider organizations do not ask the patient's consent for whether they can use open evidence, right? Based on generative AI. So we also have a set of ECG dashboards, for example. Sneha, you're a cardiologist, that have been developed that take a simple ECG signal and break it out into multiple different views from that signal using AI technology. And that allows the cardiologist to actually order that as a part of a cardiology visit and have different perspectives on a patient's risk, and indeed give them a physiological age that they can compare to their chronological age, and then help to talk with the patient about, what will help here? Exercise will help. This will help. This will help to be able to bring your physiological age down because you have these risk factors based on the AI technology. Now, as that gets more and more baked into just the ways that they're doing it, they order that just like they do other things. I'm just pointing out the practical reality of, how do you actually, have a patient consent or have that individual transparency for every AI-enabled technology you're using. So I think that's a little bit of the, sort of the back and forth. Last example that I'll give is always keeping in mind what's the benchmark against what's happening today. So we have another technology that we are now piloting, and other healthcare organizations across the country have a similar type of technology that a radiologist in a typical hospital setting, for example, or a big academic medical center setting, for example, like Mayo, will come in the morning. I talked to a radiologist just earlier this week who said, I got in at 4:30 a.m. because I had to review 125 chest x-rays today. Think about that, 125 chest x-rays they're going through. Now, we have a tool that we're now piloting that we've co-developed with Microsoft, and we're doing a bunch of work on that that will save them 30 to 45 seconds per chest X-ray with the same, but at least, early indications. Obviously, it has to be proven. We have to do a lot more work on it, but the early indications from the early studies are that it'll save 30 to 45 seconds per X-ray with at least the same quality to generate a first draft radiology report for them, that then they're still responsible for the report, right? At the end of the day, the radiologist is responsible for reading that report, signing off on it, but it saves them 30 to 45 seconds with some confidence that it is at least as high quality as, as most of the human readers who are a part of that. That's a tremendous benefit if you think about the benefit to the patient and the benefit to the provider, and you think about how many more of those technologies we're going to have. And then again, the practical reality of how much, can you actually convey in a way that's going to be meaningful to patients. We did, with Health Information Exchange, we always ran across this, Grace is very familiar with this, that, sometimes we say consent, 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 but then we hide behind it because you end up giving fine print of 3 pages that the patient actually doesn't even read, and that actually isn't meaningful, participation or meaningful understanding of what's going on. So I think that's a little bit of the balance here, and I'd strike that same analogy to what's been done with data exchange to say, how do we think about meaningful consent and meaningful transparency, and not just, superficial transparency around things that, that end up being not accomplishing what it is that I think all of us want to be able to accomplish.
I want to also add, I think there's 2 issues as it comes to trust. And one is around, I think there are some generational issues as well, in terms of, I find younger patients are much more interested in sharing data and using tools, and older patients, stereotyping a little bit, are more kind of, what do you think, doctor, and advice. But something I'd reflect on just hearing the other panelists is there seems to be very much a focus on either inpatient care or higher level care that we're talking about. And one could make the argument that the real value of innovation is in an outpatient setting and outside the hospital wall. So even as you talk about cardiology, I could say maybe the real value is HRV, heart rate variability, and how do I use innovation to measure that? I mean, I've talked before about where are we on blood pressure? People want to talk about the number of steps. If we could continuously measure blood pressure in an outpatient setting in a meaningful way, we could reduce cardiovascular risk dramatically. So we're not at the point when a patient comes in and we have to think about structural heart disease and other issues. And there are many incentives as to why we focus on inpatient settings, but the real value is before they get diagnosed with cancer. How do we use innovation and AI tools to do that? And that's not where we're seeing enough the innovation that we need.
I'm really glad that you brought that up, because I think that it becomes about more than just the technology, right? It's not just that the AI tool can give us information. How do we act on that information to create patient benefit? Grace, I saw that you wanted to add on to this a little bit.
I love the emphasis on before they're diagnosed, but the majority of my patients are diagnosed and they cannot get the care. Just this morning, I had a patient say, triple negative breast cancer. I can't get anyone to call me back. I just want this MRI rescheduled. No one's answering my portal message. I've left a dozen messages. I'm faxing. I'm taking the day off and I'm going there. And I said, I don't know if that's a good idea, because likely that office is not scheduling it. So we're losing patients in this process. And there's an opportunity, I think, across the entire patient journey in the outpatient setting to benefit. And how do we use that? I think we're stuck in, I love there was a conversation about metrics and how we measure. We're completely missing the mark on metrics that we should be capturing, because we can use the outpatient setting to boost, that is engagement. This is patient engagement. All this chat GPTing and the portal messages that we're seeing, that is patient engagement. We don't count it as that. We're able to capture and bring patients in if they get credible information that would say, here's where you need to go next. Most patients just want to know what their next step is. Help me untangle this mess. I don't know where to go. Who do I talk to? My primary care doctor can't see me for 6 months. That's just not going to work. Something else that we're not talking about, everything is very AI focused. But thanks to the efforts of the national coordinator, Micky, and many of his other colleagues, we have access to our medical records, more information than ever before. And people are using that. And I think post-pandemic, where we all were left to try to figure out how to connect to care, how to connect to COVID tests, how to connect to routine care outside of COVID, the population is just savvier. Now we have technology, tools, and information, and we want to be able to use that. But when patients use it, we discredit them and say, oh, you're not ready to do that. This isn't ready for deployment. It's going to hallucinate. I just want to share, it was also mentioned before that doctors also make mistakes. I'm a cancer misdiagnosis patient. I was diagnosed with advanced lymphoma. I took my medical records and went to a second opinion at Sloan, and it took 4 months of biopsies that were inconclusive, very invasive, numerous tests, endless imaging, constant blood work, video-assisted thoracic surgery, and waking up after surgery, being placed in isolation, finally being told it wasn't cancer, but they didn't know what I have for another 3 days, but they thought it was tuberculosis. And the ultimate diagnosis was histoplasmosis, a fungal infection that I got on my honeymoon practically 2 years prior that needs no treatment but just monitoring. That was my wild 4-month ride. Had I had an AI tool that would read my radiology and said maybe, hey, this is an advanced lymphoma and we don't need to treat this, I would have loved that. So I think there's an opportunity now.
Yeah.
We're trying to drive change from top down, but I think let patients and communities help bottom up.
And this gets to a concept that was described before about, we shouldn't compare AI augmented care to the best possible care that anyone could ever receive. We should be comparing it to the real care that patients are getting every day. Right. And so to tie this back to trust, when we think about how we evaluate these tools or monitor them over time, which is probably more important, monitoring over time, what's the benchmark? What's the thing to compare to? And does that differ depending on the setting in which a patient is receiving care or a clinician is practicing? Anyone who wants to.
Yeah, and I think, again, we'll see what happens in the federal regulatory front, because that sets a little bit, I don't even want to call it a floor, because there are some things that the regulatory approval, I think that people think that an FDA regulatory approval does more than it actually does. So let me just say that.
Can you go into that a little bit? Because I think that's really important for the
Yeah, I think that there is a sense that, this has gone through all sorts of validation from a performance perspective, from a safety perspective. The vast majority of AI-enabled technologies go through the 510K pathway, which is basically attaching it to something else, which means that you don't have to submit a whole bunch of pre-market stuff. You don't have to do pre-market validation. You can basically say, oh, my AI technology is kind of like that thing that you approved 5 years ago that wasn't really an AI technology.
But it can also be software as a medical device, which is a whole other
Well, I'm talking about software as a medical device. This is all software as a medical device that I'm
but
talking
many
about.
of them will want not to be a device. That's part of the challenge.
Well, yeah, no, but I'm talking about the realm of software as a medical device and the pathway that most AI technologies have gotten approved by the FDA go through that process. And I'm not criticizing the process. I'm just pointing out that that they don't go through the kinds of rigor that you would think that for like a PMA, right, the highest risk kinds of things, like an MRI, for example, goes through all sorts of very rigorous kinds of processes for validation in patients.
And Micky, is it right? It's over 95% go through the 510K pathway.
Yes.
Well, that's devices in general. That's not just AI tools.
No,
devices.
It's devices in general. It's if you look at the 1,000 that have been approved by the FDA, it's about 95% of them went through the 510K pathway. That's exactly what I'm talking about.
But it's the same for devices in general versus AI. The only reason why I say that is we're not holding them to different standards.
But that's I'm not talking about a different standard. I'm just saying that people think that the FDA approval does more than it does for the AI solutions that we're talking about here. But I think that we also do need to balance this question of, and I think Grace was getting a little bit at this, is we've got the rocket science, and certainly Mayo Clinic has got a ton of rocket science going on. We have like 350 to 375 internally developed solutions that are in the pipeline right now. That doesn't include what comes through Epic, doesn't include a bridge, Ambience. These are internally developed solutions that are making their way up. So so that's why, we've got the practical reality of, well, how much can we say about every single technology that's coming through? Because there are literally hundreds in the pipeline. But I would also point out that we do need to balance this question of AI technologies can give access where there isn't access. So the idea of comparing it to the current, and within Mayo, we'll compare it to, well, how does the human practice work today? Like I was describing the x-rays, for example, and saying, well, geez, if this is equally high quality, but it saves time, then you've done a lot. For the patient, you've done a lot for the provider organization. But something like 80, I forget the exact data, but I don't think I'm far off, something like 75 to 80% of counties in the US don't have a cardiologist within like 100 miles, right? And you just think about that for a second and think, what would the patient want if you told them, you know what, we created this technology that, is a virtual app that can do some cardiology screening for you. It's been through this kind of rigor and it's 75% accurate,
right,
whatever it is. In a medical setting, that might be like, not good enough, sorry. If you ask the vast majority of patients, they would say, absolutely, please give it to me.
Yeah.
Because I can't even get to a cardiologist. And that's not even counting places that don't have access to primary care in the US, let alone in other countries.
And
I think that's a little bit of the balance that we need to look at.
Yeah, and we heard a little bit about this earlier today, about how the regulatory kind of appetite is different globally depending on what you're comparing to, which I think is really valuable. I actually want to take this moment because we have about 11 minutes left till we go to the audience for questions. I want to think a little bit also about the clinician, and I want to ground it in an example. So at Stanford, we've deployed something called Chat EHR, and this is a chat system within the electronic health record that pulls data from the patient's chart itself, and the physician can chat with it. So I'll give you an example. In my day-to-day practice, when I see someone in an outpatient setting, I want to know what's happened to them in the past 6 months since I see them. Usually that means clicking through about 30 to 40 clicks into all the other subspecialists that they're seeing, looking at their records, looking at their what Care Everywhere data. We use Epic, and Care Everywhere is looking at other health systems. With Chat EHR, it pulls all of that information, so I can ask one question to summarize what's happened to the patient in the past 6 months and get a really nice summary about what has happened. Now, can hallucination happen? Absolutely. And this brings me to my question, which is, right now, the liability and the responsibility of checking the generative AI tool remains with the physician. And in some sense, this makes sense, right? The physician is the one providing care. They are the licensed one. It is their responsibility to make sure that information they provide is accurate. But when we make the argument that these tools are supposed to be making physicians faster, maybe one day require them to see more patients to solve some of the access issue, I think we have a responsibility on the trust standpoint to also accelerate the ways that physicians can do quality control. And I'll give one example where we're doing this is citations. So when you get some sort of generative AI output, you can hover over the screen so you know where it came from in the chart, so the physician doesn't have to go through and click those 40 clicks I was talking about just to check. And so I feel like there's not enough being talked about when we think about efficiency of AI tools with the work that is combined there that clinicians need to do, and compensating for that work and not just expecting them to be faster. John, I'm looking at you because I want you to talk about this.
And I would, and I'm trying not to be the argumentative one on the panel, but I would take issue with your definition of efficiency. I think your definition of efficiency is from a health system perspective of the doctor should see more patients. And I think if you ask most doctors, no doctor will say, I want to see more patients during the day. I want to spend more time with my patients. Yes. I want to have a more comprehensive assessment. So that's what that tool should be used for. So I can do more during this exam and actually have a more comprehensive follow-up plan and not to now see more patients. And I see that with a lot of tools, how they advertise and market. That's how they define efficiency. And efficiency is more about getting a better outcome, not necessarily based on time, with fewer resources.
But I have a question for you here, because as a physician, I totally agree with you. Most of these AI tools, when they're selling to healthcare systems, they're selling to the CFO.
Oh, absolutely.
They are not selling to the physician. Yeah. So how do we think about capturing maybe that value that you are outlining, and helping bring that into the decision making about what tools should be deployed and how they should be deployed? And maybe, Micky, I can go to you as someone who's at the health system level, also at the regulator level previously. How do you think about that? capturing value of AI tools that is not just financial and time efficiency?
Well, for a lot of these, I guess I would argue that there isn't, an ROI in the sense that a CFO, a hard-boiled CFO would recognize, just because of the convoluted economics of healthcare, right? It's very hard to, sort of say, here's my return, it's going to, be this X many dollars. A lot of the things that we do, to your point, are in, time savings. I think it's a very fair point that John raises, and it's a workforce issue that, that I think for a lot of the workforce, certainly our healthcare professionals, nurses, physicians, sometimes that is said, and what they hear is, great, I'm going to get 2 more patients piled on me. I think that's absolutely true. That's not good for the patients, that's not good for the providers. So, we try to work really hard to say that is, about being able to, certainly in places like Rochester, and you have limits on how many people you can hire. And so there's, that ends up becoming a hard constraint. So you want to be able to say, this is making it easier for you to do an already difficult job with these kinds of tools and, being able to do that. But I think that there's always, sort of a back and forth there. I think one of the challenges of, of trying to, sort of build trust in the validation of these systems and, and these kinds of things is like, again, you get to some of the practical realities of this. You have, well, I'll give 2 examples. One is for like a radiology type of system, you want to do what's called a reader study, right? Which is against, it's comparing it to current practice. So you basically say, well, I've got this AI tool, and we're going to get 12, I'm making this up, 12 hours, 20 hours of radiologist time where they manually review, go through the existing process they have, and then we compare it to the AI, right? And you think, okay, I'll get 10 radiologists, they'll do 2 hours each. The elapsed time of getting 10 radiologists to give 2 hours each for the ones who are seeing 150 a day, literally, it'll be like 10 months later, we're still waiting for the reader studies because the doctors are so busy, right? So that's like the practical reality of, man, how do you get these things out when, when everyone is too busy to think about the things that might give them greater efficiency, right? It's, the classic dilemma. The other thing is there's a lot of nuance, I think, in how you think about mitigation of some of these, the potential risk issues, like the summarization tool, for example. We have, I'll put side by side 2 summarization tools. We have a summarization tool similar to your EHR chat that we developed within Mayo that summarizes, the Epic record, outside records, not only just care everywhere, but even outside records that come in as scanned documents, other kinds of things, versus the radiology one that I was describing before. The clinician is responsible on both of those things. I would argue that we want to actually do more diligence on the validation of the general summarization tool because the human oversight there isn't quite as intensive or specific as it is for the radiology tool. And the reason I say that is that a radiologist, they know they are responsible for the radiology report. So they get the summary from that and they are signing off on it, right? Because that's what they do. They go through every single line and they sign off on it because that's what a radiology report is. A general summarization tool, you actually don't know if it missed a whole bunch of data, right? And we've actually, unfortunately, had the experience where this summarization tool, based on a large language model, was missing certain records, but there's no one there who is actually looking to say, wait a minute, is this missing something? Whereas a radiologist would be doing that, right? Yes. So you think about the different kinds of risks. You might think in your head that, oh, the radiology one is clearly higher risk. I would argue, well, with the human intervention, the human oversight there, actually there's a mitigating factor over here which gives us more comfort with this tool than with the general summary one where we're going to say, you know what, you have to meet a higher bar to be able to just say we're going to make this available to everyone, because the automation bias problem with that is the provider will think, oh, I've got all the records, when there's no indication to them that they don't have all the records.
So this is really interesting because it's getting to different types of evaluation for different tools, and then I want to ask
mitigations
and different mitigations, yes, and different mitigations for different tools. What about what information needs to go to the patient, to the physician, based on these different types of tools? Is it, for a long time there was all this focus on model cards. Is that, something that's actually going to be helpful for agentic AI tools or generative AI tools? What about the monitoring piece? How often do you need to tell physicians and patients about how well things are working? Thoughts, Grace?
I'm going to back it up even further. So when patients are looking to select their care, Micky, you mentioned that Mayo has 375 in their pipeline. Gosh, I would love to know that. Because patients are looking, so we're looking at the lens of being financially responsible and the lens of financial toxicity, which is a known side effect of cancer care. So when a patient goes from their local community center to go to a center of excellence, that's a big decision. It's a bigger decision if they have to go to a trial or they have to travel somewhere thousands of miles away. We don't know what anyone has in their pipeline because we can see the bios of all their physicians, There's no catalog online that says, okay, MD Anderson is using this to read radiology, and Mayo is using this, and Stanford is using this. Those things matter. Am I getting duplicate care? If I went to MD Anderson, now I need to go for a third opinion. Do I go to Stanford or do I go to Mayo? But what if you're using the same
Mayo.
thing? So I need to, well, no comment. And there's costs incurred across all of these. So, when you look at it, I was sitting in an Uber and the Uber driver said, well, I have lung cancer, but I'm not going to get care. I'm just going to drive my Uber as long as I can because I don't want to bankrupt my children. So it's not a matter of connecting to care, going to the ER. It's a matter of connecting to care. Do I pull my whole family under for the next generation? So we're also not looking at the way that people make decisions and communities make decisions about how they pursue care. And I think AI has a lot of potential to help with that. Yep. But again, doing some basics, yes, model cards are great, but we have a lot more work and background because people are engaged and need to connect to care that's important. And then they want to invest their even limited resources if they have that information that it's going to help me, it's going to help Abuela, it's going to help my child.
So it sounds like it's not about, tell me if I'm summarizing this correctly or totally off. It's not about just the one-off AI tool, but the entirety of the care and what they will receive and having some way to kind of evaluate that.
Absolutely.
Okay.
But I think that then comes to your point that you've described over the last hour, that at the end of the day, patients want someone that understands them, that gives empathy. And that's why they're calling you and trusting you, because you understand their journey and you're telling them how you're going to help them get better. And I think that's an important element. And we used to see that years ago, which I think is different, where if you told someone that they had diabetes, right, and you say things during the clinical exam, they're barely going to listen to any of it. And what they're going to do, in the past, they would go home and they'd Google, because that's all they have, and they'd read a whole bunch of information. And then what's the next thing they typically would do? They'd say, oh, your cousin has diabetes, or this friend of yours has diabetes, and they call someone who's going to help explain it to them at a different level that they trust. So I think that's the challenge as well, because when you put it into that comprehensive package, right, all the tools that they could use, and we could have all that transparency, but at the end, they want advice and who they can trust. And it's still very much their doctor that at least they want to trust in terms of the decision making. And that's what I think complicates matters.
Can I add?
Yeah, of course.
Yeah. Let's say that your health system had every tool that you had, and now you have ratings that patients use this, or doctors and patients had success with this specific tool. There's no feedback on which tools are effective. Even if I look at the website on the FDA, all of the different tools that are approved, I have no idea what's actually working in which community, in which location, at which health system. So there's this feedback. I love that, keeping that AI in the loop and using humans example. We need to put more humans back into this, because we're sort of lost in this wave of AI. And how can we have people, the physicians, the clinicians, the end users, putting more feedback into the system to inform how we use AI?
And I think that's interesting, because there is a lot of informal peer-to-peer learning happening. When a health system starts using a tool, they have a good, like, there's so many phone calls that I'm sure everyone on this panel has been on, like, oh, this tool has been really helpful. It's not the traditional clinical trials and best, tool that has emerged. Now everyone is going to use that. And we need something better than this informal access to information that only some people have access to. So I think last question, then I would like people to start raising their hands for questions, and we can start, going around, is what is the level of evidence for maybe higher risk tools? Let's just focus on higher risk tools. Is it a clinical trial? Is it more observational causal data like the health economists do? Is it more formalized peer-to-peer feedback? What does everyone think? Micky, let's start with you.
Yeah, I think it varies a lot. I mean, one of the things that is kind of the operational reality as we're seeing, because we have so many internally developed tools that we do have to sort of be very thoughtful and very proactive in how we think about that. Where you may have other systems that most of their AI, I mean, every system is going to be having AI, but in some places it may be that most of the AI is coming through vended solutions. You have a different problem there, but a lot of it is, you're not the manufacturer, you can contract for a certain set of things, and you're not in the guts of it, so you don't have the primary responsibility for evaluating it before you actually deploy it. And you have a certain degree of comfort that it is a vended solution. Whereas the internally developed ones, we have the responsibility and we have to think about it, from soup to nuts. So I don't, there isn't a single way. I think that's one of the challenges, right? That with some type of tools, there is a quantitative set of metrics that you can do. You've got an AUC, and that is meaningful in certain ways, and 0.93 versus 0.82 is actually meaningful. But there are other kinds of things that don't lend themselves to that kind of evaluation, and you're doing more of a rigorous, more qualitative kind of assessment to assess what's the value to it. And then this balancing of risks again. Just that example I gave before of the summarization tools. It's not obvious what's the right, sort of balancing of risks. And, from our perspective, we want to be thinking more about how do you think of risk in a holistic manner? So that you have the opportunity to say, well, it's not just about everything that I'm able to do, pre-deployment, because there may be a set of things that I say, you know what, we can manage the risks once it's deployed through post-deployment monitoring of the systems and very heavy human oversight, like the radiology thing that I was talking about, that would give us greater comfort of putting something that might be seen as a high complexity thing into the field so that we're able to do that, but we're able to closely monitor it while it's deployed. Whereas another thing, you may say, well, I actually don't have a good enough set of controls on the post-deployment because I can't do the monitoring as nearly as well as I'd like to, or the human oversight doesn't really look like it's nearly as intensive as I'd want. So I'm going to put more on the pre-market side to say, no, you need to do more upfront validation, kind of testing. So it really is very heterogeneous in our experience.
Oh, thank you. I want to make sure we have time for audience questions. So, and I think I just want to say that it's great that we have some discussion and disagreement up here because it shows that many of these questions are not solved questions. And
John's the only one disagreeing.
Yeah. John, okay. Only John. Go ahead, please.
I made the comment before that I think we're still in sort of the dial-up phase of AI in healthcare. As panelists, you all get one wish. What is your wish to move us more towards the 5G broadband phase of AI in healthcare? Just one thing each.
Grace, let's start with you.
Come on. I'm thinking top of mind, the National Suicide Hotline. We just had this conversation that when a patient has suicidal ideation, they can call a standardized number and there is a national level of support. I would love to see, let's start with a use case. I'm going to be biased because I work in oncology and that's my love. A national hotline where someone can't get the care they need, a diagnosis that they're uncertain, not responding to standard of care, need a trial, right to try. They call a number with their challenge and they're connected. And it's not necessarily just to AI, but AI could power this, but we also need humans there to help. That would be sort of my wish right now. Connect so every patient has access to almost an advocate at the speed of dialing a few numbers.
Amazing, John.
Similar to that, I'd say there has to be equal access to innovation, and I think rural hospitals are particularly at risk of missing out on some of the innovations that are being developed. Grace and I were chatting beforehand. I think when we think about equal access, it's as simple as that everyone with a cancer diagnosis should have a second opinion driven by AI, that cancer care is not routinized, that community oncologists are dealing with a variety of cancers. There's no way they can stay abreast as best as they can on all these areas. So how are we developing a system that provides that equal access?
Yeah, I guess for me, and this may seem odd, but it's moving very, very aggressively toward value-based care, because I think we're just about to come at the point where these systems start to look unaffordable, or we start to see, of the 1,000 solutions that have been approved by the FDA, something like 98% of them actually don't have a market. They literally aren't sold. Now, you could argue maybe the FDA process, squeezes all the creativity out of them. That would be one argument to make. But the other is that the economics of our fee-for-service system don't really, sort of have a way of compensating people for taking these technologies and saying, you know what, I think this is really high value and it's going to pay off for patients and we want to put it out in the field. So I think that we need to be much more aggressive in that. And one of the things that we're finding is that there's a lot of attention paid to the development cost of these things, but it's actually the ongoing cost that is way more than we thought. The compute and storage costs for what are even simple, seemingly simple solutions. And our Google Cloud bill is unbelievable. The ongoing costs of these are way more than people think. And so I think that's going to be a coming challenge as people start to say, these are great ideas, but our fee-for-service system doesn't support it.
And my wish is to erase the line between healthcare or health and evaluation and research, if you will, to try to think about how in the delivery of care or in the delivery of health outside of the healthcare system, how we use those ongoing daily operations to generate the evidence, to build the trust and the innovation we need, instead of saying, we need a clinical trial for this. We need some separate artificial evaluation. We need X, Y, Z. How do we bring those two together? Any other questions here? Daniel.
Hi, terrific panel. Micky and John, both of you have undergone recent career changes. Micky, you went from regulator to regulated. And John, you've gone from what was in many ways a consumer-facing platform to now really a physician-facing platform. And so the question is, what has surprised you as you've made these transitions? What are some things that you might have shared with your prior self a year ago, things that you've learned, insights, perspectives that you've gained in these new roles?
Want me to go first? Sure. So, I guess I would point to two things. Well, one, I have had the unique experience of having been the regulator and then going to that side and looking at the regulation and being like, who makes this stuff up? Like, unbelievable. I'm only kidding. No, I think the thing that has surprised me the most, and I don't think it's just because I'm at Mayo Clinic, is how fast this innovation is happening. I didn't expect to come into an organization where we had 375 solutions in the pipeline, up to a third of them now, generative AI, and we're building our own multimodal foundation models. These aren't vended systems. We, within Mayo, we have a Blackwell cluster. We're building our own multimodal foundation models. I didn't expect, if you had asked me in January when I was leaving, how far off are we, and Stanford's doing the same thing, the organization's doing the same thing. If you had asked me how far off are we from that, I would have said 3 years, maybe 4 years. And then I enter Mayo in May, and it's like, oh, we got 10 of these going on and 350 solutions, and your job is to figure out how to get them into the bedside safely and effectively and as quickly as possible.
What I would say, Daniel, is I think there's actually a lot of synergies because it's all a continuum, whereas I think both for physicians and the public, they're interested in the user experience of these technologies and tools, maybe from a little bit of a different usage perspective, but the usability is very important. I think the issue of trust is important, that patients want to know, can they trust this information that they're getting online, say when I was at WebMD, and doctors want to know that, if they're using open evidence or other tools, that is this being summarized well, and can I trust it? And then the validation of it. How do I know that this is the most up-to-date? So it's actually remarkably very similar in terms of the categories that folks are interested in, whether they're a patient or a physician.
Thank you. Other questions? Yes.
Hi, good. Sonia Allen Smith. I have a question. First of all, I really want to say that it is very refreshing and it scratches my soul to hear the advocacy around educating the community and the members about the importance of AI. Thanks for the advocacy on it, because the patients do want to be engaged in their health care. But I also have this question as a worker within Kaiser, rank and file worker, is to ask, how are we educating the frontline workers that are working with the patients that AI is, one, not there to take their jobs, but there to help the expedience of healthcare, just as we displayed here. Because when we talk about trust, the first person that a patient comes in contact with is a receptionist or a allied healthcare worker. But what is the conversation happening on that front end to help encourage the utilization or the involvement of AI with our workforce in healthcare?
John, Micky, do you want to take that on the health system side?
Yeah, I'm happy to start. So I think, thank you for the question. It's a great question. It's an ongoing conversation, I think, because I think people have genuine fears and you know, and understandable and valid fears. I think, you know, certainly within healthcare, I think there is the reality that, you know, that our problems in lots of places are that we can't hire enough staff, that we can't find them. And so the ability to be able to alleviate some of the, you know, the kind of rote work that burdens nurses, frontline, you know, healthcare professionals in general, and the administrative staff, all are, you know, sort of burdened by all this rote work. And if we're able to alleviate them of that and then, you know, give them the opportunity to do more, I think that that's, you know, something, an ongoing conversation. And obviously that, you know, the proof is in the pudding. I mean, I think that what we've been doing, we've been trying very hard to you know, to reinforce that messaging. And then when we do it, we actually show them that, look, this didn't lead to, you know, huge reductions in force. This actually did lead to your being able to spend more time on the things that, you know, that you as a human are, you know, best able to do, and taking more and more of this routinized stuff off of your plate. The other thing that, that may be a little bit unique to Mayo is that, as I described before, we have all of these solutions that are, you know, really organic. We don't dictate where people can innovate. And so one example I'll give is we just are rolling out a solution that we call the nursing virtual assistant, which was developed by the nursing department. So it's nurses themselves who are developing solutions, and now we have, before the end of the year, we'll have 9,000 users, nursing users, who are on this medical summarization tool that's specific to the nursing experience. And so there's no substitute for solutions that the people who are doing this day to day come up with a solution themselves and saying, here's a problem that I want to solve, and then, you know, then being able to use it. So I think we're having, you know, again, that'll vary a lot by department and, you know, what we're talking about, but I think that's another part of being able to engage them directly and how these technologies can be useful to them.
And I really think that that's worth highlighting, underscoring, is involving the end user in the design, deployment, and monitoring process. And this is true not only for our healthcare systems, but also, and I'm sure that some of our, you know, colleagues here who are from Google, Buckle, and others are using that end user feedback throughout the process, so we're actually solving problems that are worth solving. So I really like that. John, is there anything you wanted to add on this question?
No, I very much agree with that. I think for the most part, no one thinks that AI is going to replace clinicians, whether it's doctors, nurses, or pharmacists, or either frontline workers. I think it's really about reducing some of that administrative burden, the other tasks, so they can perform really at the top of their game in other areas.
Mm-hmm. We have a long way to go to improve healthcare generally.
Supposed to be the end of radiologists, and we can't hire enough radiologists still to this day.
I think the bigger issue there, to your point, although a lot of it is about frontline workers, is how do we use innovation to address the workforce? There are not enough physicians. There are not enough nurses. There are not enough pharmacists. That's not going to get any better in the short term. So what is the role of chatbots? What are the role of innovations, these other tools? That's really the next discussion that we need to be having.
And I think a lot of health systems are investing in upskilling their workers so that they can best use AI tools to do their jobs well and to solve some of these bottlenecks and capacity constraints you all are talking about. Great. Other questions? Okay.
Hi, Caroline Lucas. Wondering about the use of AI as you routinize some of the more mundane tasks. You're really asking physicians and other providers to operate top of scope at the very most complex level of decision making at all times, without kind of that rest that some of the mundane tasks do allow for. How do you prevent the brain strain that happens when you're continually asking folks to focus at top of scope all the time?
Mm-hmm. John?
Sure. I mean, as you know, we're very focused on people practicing what their license allows them to do. And there's issues of scope creep where we have some concerns as the American Medical Association about people practicing beyond the scope of their license. But I think you raise a very good point. It's about how do we manage complex cases better, to your point, in terms of misdiagnosis. And that's a challenge, that no one wants to have that high level acuity every single day. I think this goes back to what I talked about at the beginning. It's about understanding workflow and how do you help manage workflow. And those are the problems that we should be solving, and starting with that. How do you manage it that way, rather than saying, oh, here we have a tool to make you more efficient, to see more patients during the day. So it's a great question, which brings in the issue of letting people practice at the top of their license, but not beyond that. And then how do we have these other tools, recognizing there are shortages? And that's why, even in my clinical time here at Kaiser, just the level of acuity in primary care is greater than it was just a few years ago. And that's where we see a lot of burnout.
And I think, John, to go back to something you had said before, I think these AI tools, yes, it will allow people to operate at the top of their license, but also do the things that are uniquely wanted, that our patients uniquely want humans to do. And that's not necessarily the most burdensome, high cognitive load tasks. And John mentioned this earlier, right? More time to spend explaining, talking face-to-face with your patients instead of being locked behind a computer. And that actually, I think, will invigorate providers rather than cause more brain strain, because that's, if you ask most of us physicians why we went into medicine, it was not to do a bunch of administrative work, and it was not to do a lot of the kind of mundane work that we hope AI will take over.
Mm-hmm. I'd like to share board-certified patient advocates, I think, just as an example, being able to access medical records, where normally I would spend, let's say, 40 to 60 hours trying to aggregate medical records for a new patient that I may be supporting. That goes so much quicker now because everything's available in a portal. I would much rather be spending 40 to 60 hours supporting a patient in the nuance and the art of medicine and the decision-making that they need to do, as opposed to filling out clipboards, going to medical record departments, collecting, images on CD. So I think removing that administrative burden allows people to get into the joy of what they got into. Do I think we should be constantly hammering? I think we need to also not continue to add more patients to already overloaded schedules and allow opportunities for humanity and connection, yes, but I don't think a lot of, from what I hear from my colleagues in medicine, they're frustrated. They just don't have the time to do the meaningful encounter. It's all the administrative burden, and at the last minute, they have to move on to the next patient.
And sometimes we think about administrative burden as, and I think our mental models, and certainly for me, I always think of paperwork. But I'll give you an example of something that we're exploring right now. It's the use of avatars for certain types of things that take up a lot of nursing time. That's very routinized. And so, for example, post-discharge management of a Foley catheter and the removal of that, right? So we give instructions to patients, and nurses will literally call every patient and walk them through a set of instructions. And you talk to a nurse, and they'll say, "Oh my God, I can do that in my sleep. I just I'm just like reading the thing." And so we're looking at, and that takes them away from being able to do the in-person kind of things that they want to be able to do for something that arguably maybe an avatar could meet a patient where they are and gives them everything that they want in terms of, the ability to communicate with them. So we're looking at voice avatars as well as even like a digital representation of an individual to be able to say, how do we understand? Some patients may like the individual or the human rendition. Some people may just want the voice, but the ability for them to just hear it, ask some basic questions, get a response back, frees up the nursing time without any deviation from what's available to the patient. And arguably it gives patients more access because they can access that according to a better time for them rather than, I missed the call again with the nurse, right? I mean,
but these
those are never going to be
exactly what I'm talking about. I, as a patient and as an advocate, as a care partner, I want to hear about these things, and we're not celebrating that. Everyone here has LinkedIn profiles.
Well, we don't have it in production yet. So.
Well, okay. Well, so we'll be looking
but those are the
forward to it.
opportunities.
There are things that are happening that are bringing more joy back to medicine, more meaningful encounters. We should be talking about that, celebrating that. All we hear about it's hallucinations, it's wrong, it's going, and all the horror stories.
Totally
but
agree.
We need to tip the scale to at least neutralize the environment and celebrate the good. I would ask everyone, please celebrate the good work that you're all doing so that patients and advocates and communities and nonprofits can see that, because that's a conduit for trust as well.
Right. And unfortunately, in the way that our system works in the U.S., I think most patients' experience with AI is that it's being used to deny them something.
Yeah. And I think that's so interesting. And I think to celebrate something and answer the question, I think looking at some things that folks at Google are building in collaboration with scientists are things like addressing how to get patients to what they need quicker, instead of spending so much time calling the wrong person to get something scheduled or seeing all of these providers that aren't the right people. And one example that was a collaborative effort between Google and some folks at Stanford was AI augmented triage to identify who actually needs to see specific specialty care, so that the specialists are only seeing patients that they actually can really help, and making sure that those patients have, they have the right imaging already done, or they're not getting routed to the right place. So easing the pathway for patients and providers so that the right people meet at the right time to get the right clinical care.
Well, then can I ask you a question about that, maybe both of
Yeah.
you? When you think about, again, just making it more practical, in mental health, we screen more now for patients with anxiety and depression, as we're aware of it, and then patients come up screening positive, and there aren't enough mental health professionals around. So I mentioned earlier about chatbots. Do you say, okay, that's good enough, and because there are no other mental health professionals, right, that we can use digital medicine, so to speak, I'm using the term broadly, so they get some level of care, although it's not a person, but it's better than no care? How do we evaluate that in terms of innovation?
Yeah, and
We
this
need
is
to ask
fascinating.
patients and talk to them about it.
Yeah.
Here's what Google did that I just want to point out, there's a very fine nuance. When that video started playing, did anyone say, oh my God, is that person smart enough to use the tool? Oh my God, is it going to hallucinate? No. We trusted the patient to use the tool. So I think when we talk about trust, trust the people too, and find ways that we can help people trust themselves to use these tools, empower them to be able to be agents in their care. And we're seeing that. People are capable. Some people do need support. That's our job. Fill in the gaps so that we level the playing field and upskill everyone together, and then drive patients and families to be partners, proactive partners and members of healthcare, U.S. healthcare, and partner with their physicians and care teams.
That's fascinating because it's really like patients as customers of healthcare. What do the customers, the patients demand from health systems? How can we get AI to help that? And that addresses, I think, part of John's question. And I think each environment, if you have, this goes back to a theme we've had where if you have no healthcare, maybe something's better than nothing. If you have good healthcare, maybe you're going to have a different bar. This is fascinating. Other questions? Yes, we have several. Okay.
Since John mentioned mental health, while we're getting this next question teed up, the FDA, I'll give a plug for the FDA, is going to have a meeting of their Digital Health Advisory Committee, I think next month. And it's going to be focused on AI and mental health. So it should be a really good session focused on the mental health issues, both with respect to access as well as the complexities.
Hi, thank you so much for this amazing panel. I'm very inspired by just hearing about all the innovations you've worked on and led. One of my curiosities is, you all sit in positions where you're seeing so much innovation, and I'm curious, what is some space where you feel like no one's really working on or focusing on that remains a huge problem that you wish a developer or someone else would address?
Okay, let's do lightning round answers to this and then close up. Grace, you want to start?
We have a right to try pathway for pharma and for drugs that may not have gone through clinical trials. We have no right to try pathway for an innovation that a patient may have come across and wishes to bring to a health system. And that drives me crazy. So I just to give you context, I work with CancerX, which is using the power of digital health to reduce the incidence of cancer, deaths by cancer, and connect people to quality and more affordable care. We have some fabulous startups that come through our accelerators. And if I have personally seen this, wanted to bring a solution to a patient who is sent home to die, who's not ready to die and wants more information, shutdown after shutdown after shutdown. How do we support innovation from the bottom up and trust patients and have a right to try pathway?
Amazing. John?
I wish we were doing more in prevention, especially in terms of lifestyle medicine. I think too many of the tools that we're seeing there are for those people that are already interested in prevention, and we're in some ways just getting the healthier. And I think that's an area where we need to see more innovation in terms of getting preventive skills and tools to those people that really need it.
Yeah, I guess I would mention two things. One is we talked a little bit about it, but I think we don't spend enough on access in general and thinking about that trade-off. Partly, I think it's because of the way we pay for healthcare, the privacy issues related to that anything that is patient-facing that isn't provided to you by a covered entity, like a health insurer or provider, is not covered by HIPAA, and that presents a huge challenge for all of us, and I think is going to be a high friction point as we think about these kinds of solutions. But I think that we don't spend enough time on that. The second is, if you go into any place, and I'll let Sneha comment on Stanford, but Mayo in some ways is a microcosm of the healthcare system at large, which is to say, if you look at where the AI activity is, I mean, it's all across the board at Mayo, but most of the solutions we have come out of cardiology, radiology, and neurology. And if you look at the FDA approvals, 90x% of those are radiology solutions. So we don't have enough activity in these other areas that in general don't get the type of resources in the US healthcare system. And the same is true in AI as well.
What an incredible discussion and panel. I want to thank you all. And I have one final question for you before we end. One takeaway from this panel on trust and innovation that you want the audience to leave with. Micky, why don't we start with you and work backwards?
I guess I'll come back to the thing I said at the beginning, is I think that we really need to be looking really, really hard at the misuse, at what opportunities are we denying patients by not using these technologies to raise the standard of care.
I'm going to steal Bakul's line from the last panel that really has been pressed upon me, that we briefly touched upon, that I think we really need a rich discussion here, particularly in Washington. Do you try it before you regulate it, or do you regulate it before you try it? I think that's the future discussion that we're really going to dig deep into.
Grace.
How many people here have a chief patient officer as part of their leadership? Raise your hand. That's a problem. No one raised their hands. So your homework is find a budget, hire patients, compensate patients, hire a chief patient officer, not just for your AI efforts, but for all the efforts for innovation and technology. And then you can have task forces, you can have workbooks, and we can all share best practices. But until we include the patient and care partner voice, we're going to keep running into the same implementation, adoption, design problems.
Thank you so much. And with that, we will end this session. And thank you all for the fantastic questions and conversation. Thank you.
Thank you, everybody, that was such a great panel. Thank you, Dr. Jain, and all the panelists for the reflections and recommendations. I also scribbled a ton of notes on my card here. But the conversation about trust, different stakeholder perspectives, the connection to payment, value, so many interesting and important learnings. So thank you very much for that. So it is now time for lunch. So lunch is going to be served at the back, buffet style, and we encourage you to come back to your seats. There's also some seating available near the buffet as well. We will begin our next session promptly at 1:15. So thank you and enjoy lunch very much.